Assalamu alaikum. My name is Hafsa Rashid. My roll number is BP1650078. I belong to group 34 and my topic name is peritoneal dialysis. Peritoneal dialysis is a treatment for patients with severe chronic kidney disease. It's a technique that uses the patient's own body tissue, that is peritoneal membrane inside the abdominal cavity, as a filter. Peritoneal membrane acts as a natural filter to remove toxic substances and metabolic wastes. Goals of peritoneal dialysis: to remove toxic substances and metabolic wastes, as patient's own kidney is unable to remove all the toxic substances and metabolic wastes from the body. Reverse the symptoms of uremia. Uremia is the condition in which there is an excess or elevated level of urea inside the body. So it reverses the symptoms of uremia, reestablish normal fluid and electrolyte balance, prolong life, and have the maximum level of quality of life. Physiology. The semipermeable peritoneal membrane allows solute and water to be transported from the vascular system to the peritoneal cavity and vice versa through diffusion, osmosis, and ultrafiltration. Diffusion is the process in which movement of solutes from the area of higher concentration to the area of lower concentration occurs. In osmosis, movement of water through semipermeable membrane from lower concentration of solute to the higher concentration area of solute occur to equalize the concentration of solute on both sides of the membrane. Ultrafiltration. It is similar to reverse osmosis, using hydrostatic pressure to force water through a semi-permeable membrane. Types of peritoneal dialysis. There are two types of peritoneal dialysis. Number one is continuous ambulatory peritoneal dialysis, capped, and automated peritoneal dialysis is the second one. First one is continuous ambulatory peritoneal dialysis. It is carried out during daytime, manually by patient or by caregivers. Dialysis fluid is infused in peritoneal cavity and dwell time is between 3 to 10 hours. It is convenient for the patient as well. In automated peritoneal dialysis, it is performed through a cycler machine. It requires a machine, so it is not easily or convenient for a patient. During the night, when the patient is asleep, it is done. Performing exchange. In peritoneal dialysis, we have to exchange, perform exchange. In for initial patients, we prescribe 3 exchanges day at day, while the fourth one is prescribed at night. So it requires 3 procedures. Number one is infusion. Dialysate is infused by gravity into the peritoneal cavity. 5 to 10 minutes usually required to infuse 2 liters of fluid. Second process is dual or equilibration. The prescribed dual or equilibration time allows diffusion and osmosis to occur. And the third one is drainage. The tube is unclamped and the solution drains from the peritoneal cavity by gravity through a closed system. Drainage is usually done in 10 to 30 minutes. So we perform, as I told before, we have to perform number of exchanges and it depends on patient's physical status. Okay, the second one is dextrose solution. Dextrose solution is the component of dialysate preparation, main component, and dextrose solution of 1.5%, 2.5%, and 4.5 4.25% are available several volumes, from 500 ml to 3000 ml, allowing the dialysate selection to fit the patient's tolerance, size, physiological need. So these are the different concentrations of dextrose solution. It depends on patient's tolerance, size, and physiological need. As if the patient is fully filled, and we have to remove a great amount of toxic substances and solutes from the body. So we need a greater concentration of dextrose solution, that is 4.25%. And if there is less amount and less fill, so we need less concentration of dextrose solution, which is 1.5%. Okay, here's the composition of peritoneal dialysis fluid. It is composed of sodium, potassium, calcium, magnesium, chloride, lactate, glucose, and it should be of pH 5.2 to 5.5. Here is the here is the standard for potassium is 0, and it is because we can give potassium to the patients who are unable to balance their body potassium. So we it's optional and it depends on patient condition. Here's a case study. MJ, a 27-year-old woman, has a 14-year history of insulin-dependent diabetes mellitus. She is 5 inches tall and weighs 60 kg. One complication of her diabetes is ESRD, necessitating dialysis. She has been undergoing CAP for 1 year and until now has done well without any complications. Her dialysis prescription consists of 3 exchanges with 1.5 dextrose during the day and a fourth overnight exchange with 4.25% dextrose. She has a double cuff, 10 cuff catheter and uses wire transfer set for her exchanges. Her blood pressure is controlled and shows no evidence of edema. She has no residual renal function. Her most recent serum laboratory result showed the following: calcium 10.9 and normal is 8.8 to 10.2, which means there is increased or elevated level of calcium. Potassium is 3.2 and normal is 3.5 to 5. It shows lower level of potassium. So MJ is noted to have an elevated serum calcium concentration of 10.9 milligram per dl, probably as a result of her calcium carbonate requirement to serve as a binder of dietary phosphate. Dialysate preparation with a low calcium concentration 2.5 compared with the standard concentration of 3.5 can help to control hypercalcemia associated with increased oral calcium intake. It means that calcium carbonate in the body lowers the serum phosphate level and increases the calcium serum calcium level. So for this, we decreases the dialysate concentration of calcium, which is 2.5, to overcome the problem of hypercalcemia. Secondly, potassium is not present in dialysis solution but can be supplemented in the patient who are not able to maintain potassium within the range. MJ has somewhat low potassium 3.2, therefore providing a dialysate concentration of 4 will sustain normal concentration and prevent hypokalemia. So here's my presentation of peritoneal dialysis. Thank you so much.